Welcome to the deep dive. Today, we're tackling a really critical health issue, vascular trauma. Trauma itself is, well, it's a huge problem. Incredibly, it's the #1 cause of death for people aged 1 to 46 in the U.S.
Yeah, that's a staggering statistic.
And the third highest cause overall. So understanding what happens when those injuries involve blood vessels is clearly vital.
It is. And our goal in this deep dive is to really get under the skin of these injuries, kind of from a big picture perspective.
Right.
We'll be looking at how historical events, especially, military conflicts, have shaped our knowledge.
Okay.
And how we gather information about these injuries today and, well, what the typical course of different vascular injuries looks like.
Yeah.
We're drawing on chapters from Rutherford's Vascular Surgery, the 10th edition, for this.
Exactly. And it's a bit of a paradox, isn't it? Despite all the advances in how we treat trauma, the overall impact seems, well, stubbornly persistent.
It does, yeah.
And when we talk about why people die from trauma, more often than not, the answer is hemorrhage, just severe, uncontrolled bleeding.
That's right.
Okay, so let's start by going back in time. Let's look at how warfare has influenced our understanding of vascular trauma.
It's a grim reality, but military conflicts have provided this unfortunate yet unique lens to study vascular injuries. The sheer volume and severity in wartime created opportunities, tragic ones, but opportunities to see patterns and, crucially, to spur innovation in treatment.
Right. Think back to World War I and II. The incidence was around 1%, roughly, of combat casualties having a vascular injury.
Yeah, relatively low compared to later conflicts.
But the outcomes were tough. Amputation was pretty much the standard response, mostly through ligation, just tying off the vessel.
Right. Repair attempts were very rare.
Very rare. In World War II, out of nearly 2,500 arterial injuries, only about 80 repairs were even tried.
Wow.
And the amputation rate was a shocking 36%. They even tried vein grafts in 40 patients, but even then, half still lost their limb.
That just highlights the limitations back then,
Yeah.
The understanding, the capabilities, the resources. Vascular surgery was really just starting to take shape.
But then the Korean War marked a real turning point.
It did. Interestingly, the rate of vascular injuries actually went up slightly to around 2%.
Which sounds worse, but...
But it probably reflects improvements in getting casualties to care faster, so more were surviving long enough to be treated for these severe injuries.
Okay, and here's where it gets really interesting. Because in Korea, there was this significant shift in how they handled these injuries.
Big shift.
Surgeons started actively trying to fix the damaged vessels. Primary repair, like stitching the ends back together, that became the goal in about 60% of cases.
And using interposition grafts, too, bridging the gap.
Right. In about a quarter of cases, they initially tried using cadaveric arteries?
Yeah, arteries from deceased individuals. But those had a pretty high failure rate, about 33%. Vein grafts taken from the patient themselves were much better, only 12% failure.
And the work of Colonel Carl Hughes during this period was just revolutionary, wasn't it?
Absolutely. His work and the shift towards repair saw amputation rates plummet from that 40% in World War II down to just 13% in Korea for repaired injuries.
That's a massive leap forward in saving limbs.
Huge. But we need to remember, challenges still existed. The time delays getting patients to surgery, the need for significant resuscitation first.
Sure. Then we move on to Vietnam, which brought another wave of progress, particularly with the Vietnam Vascular Registry.
Yes, that was a major step forward, a systematic way to collect detailed info on thousands of these injuries, nearly 10,000 documented.
Wow.
And this data, analyzed by people like Rich and his colleagues, really showed that repairing vessels 93% were repaired led to much better outcomes, lower amputation rates.
Okay.
And there was also this growing understanding about repairing veins, too, not just arteries, to improve limb salvage, though that faced some skepticism initially.
Right, that makes sense. Now, fast forward to the Global War on Terror, or GWOT. This recent period, obviously different challenges, different kinds of warfare.
And further innovation, definitely. The focus has been not just on reducing deaths, but also improving long-term function for those with severe limb injuries.
Okay.
The Joint Theater Trauma System and its registry, the JTTR, have been absolutely vital here, setting guidelines, using data to improve care.
And the GWT Vascular Initiative specifically looked at long-term outcomes.
Exactly. A deeper dive into injury patterns and recovery. And a really significant early advancement was the widespread use of battlefield tourniquets.
Those tourniquets really have been a game changer, haven't they? I know there was some debate early on.
There was, but their effectiveness in stopping severe bleeding right on the spot before reaching a hospital, undeniable.
Yeah.
It's actually meant more patients with these very severe vascular injuries are surviving long enough to get to medical care.
But the nature of the injuries changed too, right? With IDs and body armor.
Correct. A shift in patterns. We started seeing a higher proportion of extremity injuries, about 53%, and fewer torso injuries.
Interesting. But you mentioned that despite efforts to save limbs, the severity of blast injuries sometimes meant more ligation.
Yes, that's a critical point. The tissue damage for IEDs can be incredibly extensive, destructive. So sometimes ligation was the necessary choice.
Okay.
But alongside that, we saw the introduction of temporary vascular shunts, like temporary bypasses during long repairs,
Right.
and more routine use of fasciotomies to relieve limb pressure, plus a greater reliance on endovascular techniques, those minimally invasive approaches.
For diagnosis and treatment.
Both, yes.
Oh.
But despite all this progress, it's still, well, it's sobering. Somewhere between 15 and 25% combat deaths are still considered potentially survivable.
And mostly due to bleeding.
In the vast majority, 87%, yes. Uncontrolled hemorrhage remains the biggest challenge in preventable trauma death.
It really highlights just how crucial good data is. You mentioned registries earlier. Let's dig into that a bit more. Why is collecting this info so vital?
Well, comprehensive, reliable data collection is just the bedrock for understanding the epidemiology. The Vietnam Registry was that early influential model.
Right.
The JTTR from Iraq and Afghanistan built on that. And in the civilian world, the National Trauma Data Bank, the NTDB, is the largest we have.
A huge resource.
Huge. It allows for uniform analysis across many hospitals.
But you also mentioned it has limitations.
It does, yeah. While it's invaluable, it doesn't capture the whole picture. For instance, patients who die at the scene or en route, they aren't included.
So the most severe, immediately fatal injuries are likely underrepresented.
Exactly.
Yep.
Plus, it's not truly population-based, only includes participating hospitals.
Yeah.
And the outcome data is mainly focused on the in-hospital period.
Okay. So to address those gaps, there's the PIROVE registry.
Correct. The Prospective Vascular Injury Treatment Registry, WWI, it was specifically designed to capture more detail, things often missing from the NTDB.
Like what specifically?
Like details of pre-hospital care. Was a tourniquet used? How quickly? Their initial data showed tourniquets in about 20% of their patients. That kind of granularity is essential.
Got it. So we're gathering all this data, but how do doctors actually classify or score the severity? Is there a gold standard?
Unfortunately, not really. We haven't found that perfect system yet. Standard scores like the ISS, RTS, TRI, they're good for overall trauma severity.
But not specific enough for vascular injury.
Right. They don't accurately capture the specific impact of the vascular injury on outcomes. You can see different mortality rates in civilian versus military patients with similar ISS scores if a vascular injury is involved. The AST-AI system grades the injury to the specific vessel, but doesn't necessarily reflect the overall physiological hit.
And what about for mangled limbs? Things like the S score.
Yeah, the Mangled Extremity Severity Score, NS and others like it, they do include vascular injury and ischemia as key factors. But they haven't proven very good at predicting, for an individual patient, whether an amputation will be needed after surgeons have tried to repair the arteries.
So more useful for looking at trends in groups, maybe, rather than predicting for one person.
Precisely. More for population-level analysis than individual prognostication.
Okay. Let's shift focus now to the civilian world today. What are the main patterns, the trends we're seeing in vascular injury?
Well, the frequency varies. NTDB data suggests about 1.6% incidence in adults admitted to trauma centers and lower, 0.6% in kids.
Which is much lower than combat rates.
Significantly lower, yeah. Combat rates are more like 6–12%. But again, remember the NTDB limitations. This is likely an underestimate because it misses those immediate deaths.
Right.
Autopsy studies paint a different picture, showing a higher prevalence, especially in penetrating trauma deaths. Aortic injury, specifically, is a major cause of immediate death in those cases.
Okay. And what about blunt versus penetrating in civilians?
Interestingly, while blunt trauma causes about half of all trauma deaths overall, blunt vascular injury is relatively uncommon.
Except for
the big one, thoracic aortic injuries. Those are highly lethal. We're also seeing this trend of an increasing average age among trauma patients.
Right. And older patients might have pre-existing conditions.
Exactly. Pre-existing vascular disease, which can really complicate things when they suffer a new vascular injury.
That makes perfect sense. Now, what factors influence what happens if an injury isn't treated immediately? What's the sort of natural progression?
Well, prompt treatment, definitive or temporizing is just absolutely critical. Improvements in EMS over the last century have been huge.
Getting people to care faster.
Right. Studies show fewer pre-hospital deaths compared to in-hospital deaths now, meaning more critically injured patients are actually making it to the hospital.
Okay.
And damage control techniques, abbreviated surgery, balanced resuscitation, shunts, they've been instrumental in reducing mortality and limb loss too.
Shifting the pattern of when deaths occur.
Exactly, more towards a bimodal distribution. And of course, the rise of endovascular techniques has been transformative.
Used more broadly now.
Much more broadly. Initially for high-risk or hard-to-reach spots, but now for hemorrhage control, definitive repair. It's led to decreased morbidity, shorter stays, better mortality in many cases, used in combat too.
Right. Those less invasive approaches often mean better outcomes. Now let's consider who's most at risk. How do age and gender play into this?
Age is significant. The peak incidence is in young adults, around 21. Motor vehicle collisions are a big driver there.
Okay.
And while firearm injuries happen across ages, the case fatality rate is much higher in that peak young adult group.
And gender.
Males account for the vast majority, over 70% of all trauma, and up to 90% for penetrating extremity wounds.
Wow. What about kids?
Pediatrics, under 16, have a lower overall incidence, 0.6%. Fewer chest vessel injuries.
Yeah.
But sadly, firearms and stabs are still major causes of penetrating injury, with high mortality for firearms. Upper extremity is the most common site.
And amputation rates similar to adults.
Roughly, yes.
Yeah.
Then in older adults, say mean age around 70.
Okay.
Similar incidence to kids, actually, around 0.7%. But the mechanisms shift. More blunt trauma falls, MVCs. Blunt thoracic aortic injury is most frequent.
Outcomes.
Tragically, mortality is significantly higher in geriatric trauma patients. Around 44% compared to maybe 16% in younger adults. Forearm vessels are common sites for penetrating trauma. Similar amputation rates, though.
It's striking how these patterns shift across the lifespan. What about ethnicity and socioeconomic factors? Do they play a role?
Yes, unfortunately, there are clear disparities. Studies using NTDB show a higher incidence of penetrating trauma among Black and Hispanic patients compared to white patients.
Regardless of insurance.
Regardless of insurance status, yes. And unadjusted mortality rates are also higher in those groups.
And does that hold up after adjusting for injury severity?
It does. These disparities persist even after accounting for how badly injured someone is initially. Other studies looking specifically at, say, isolated lower extremity vascular injuries or pedestrian injuries have also found race, Black American or Hispanic, and being uninsured are independent predictors of increased mortality.
Why is that?
The reasons are complex, likely multifactorial, and probably not fully captured in our current databases. It highlights a real need for more research and targeted interventions to address these inequities.
Absolutely. Those are really crucial issues. Okay, let's shift gears to the mechanics. How do these injuries actually happen? Ballistics, biomechanics.
All right, so blunt trauma, mostly MVCs, usually causes damage through stretching, shearing, or complete tearing avulsion.
Okay.
There's also the water hammer effect, a sudden pressure surge inside the vessel. And sometimes bone fragments can cause penetrating type injuries even in blunt trauma.
And penetrating. Stab wounds versus bullets?
Yeah, so stabs or punctures are lower energy, more direct injury, less surrounding damage usually.
Yeah.
Missiles, bullets, shrapnel involve significant energy transfer. Depends on mass and velocity, but also
other factors.
Right. Shape, deformation, fragmentation, they all influence tissue damage. Missiles create a sonic wave and a temporary cavity that can damage tissue far from the actual track.
Interesting. What about microscopic damage nearby?
Research suggests aggressive debridement of seemingly normal vessel sections near a missile track isn't usually necessary, despite potential microscopic injury.
Okay. And shotguns?
Unique. Lower velocity usually, but multiple pellets cause diffuse devascularization. Then there's blast injury IEDs.
A combination of things.
Exactly. Blunt force, penetrating fragments, thermal injury, now outnumber gunshot wounds for vascular injury in combat.
Classified into different effects?
Primary, secondary, tertiary, quaternary. Most vascular injuries come from secondary to fragments and tertiary, being thrown by the blast.
And those have high amputation rates.
Especially blast-induced extremity injuries with fractures, yes. And tragically, we see these in civilian terror incidents too.
So the mechanism really dictates the damage. Okay, let's get specific now. Different parts of the body. What about the neck?
Neck injuries, vascular-wise, are more often penetrating in civilians, about 20% gunshot, stab wounds. Blunt is rare, maybe 1%.
And the vessel most involved.
Carotid artery. Blunt carotid injuries often happen from hyperextension, affect the distal internal carotid, and often come with other injuries, like brain injury.
And CT scans help diagnose these.
CT angiography has really improved diagnosis,
Yeah.
Mortality can be significant. Vertebral artery injuries are less common, but often linked to cervical spine fractures, up to 40% incidence if there's a fracture.
Risk of stroke there.
Risk of posterior circulation stroke, yes. Early CT angiography is key.
Okay. What about the torso, the chest and abdomen? Sounds critical.
Extremely critical. Injuries to major vessels there are highly morbid. Many patients die pre-hospital. Battlefield studies showed almost no survivors with named vessel injury in the torso.
Wow.
Non-compressible truncal hemorrhage, NCTH, has a very high mortality. 60–70% of preventable civilian deaths.
So what are the keys to managing that?
Rapid transfer, permissive hypotension, letting blood pressures stay a bit lower.
To avoid blowing clots off.
Exactly. Hemostatic resuscitation blood products, TXA, damage control surgery, maybe shunts, and WWII, that endovascular balloon occlusion, is being explored pre-hospital.
Okay, breaking down the thorax more. The aorta.
Thoracic aorta injuries are mostly penetrating, 90%. But blunt thoracic aortic injury, BTAI, usually at the isthmus, is incredibly lethal. Causes about a third of blunt trauma deaths.
And how are those classified?
Based on severity in intimal tear up to rupture. There's a newer 3-tier system too. Minimal, moderate, severe, based on the aorta's shape on imaging.
And treatment has shifted.
Definitely. For blunt descending aortic injuries, TEVAR endovascular repair is now primary. Better outcomes, lower mortality, less paraplegia risk than open surgery.
Okay.
Delayed repair might be used for less severe grades if other injuries are priority. Endo is also used for penetrating injuries, pseudoaneurysms, sometimes non-op management for very low-risk ones.
What about the other great vessels? Innominate, subclavian.
Often, fatal quickly, 90% within 30 minutes from bleeding. Gunshots more common than stabs. Blunt is rare. Isolated subclavian injury is still very high mortality. Often multiple vessels are hit.
Repair is usually open surgery.
Typically, yes. Sternotomy or thoracotomy, vein or prosthetic grafts. Good long-term patency, usually. Interestingly, sometimes ligating the subclavian is tolerated because of collaterals.
Supported by TEVAR experience.
Right, covering the left subclavian origin. Long-term issues are often neurological from nerve damage.
And the axillosubclavian region, where the neck meets the armpit.
Yeah, that cross zone. Proximal subclavian is like the great vessels. Distal injuries are often penetrating, shotguns common. Vein injury is frequent too.
Blunt injury there.
Rare, but often with clavicle fractures. High rate of nerve injury, amputation 3–15%, mortality up to 25%. Worse for blunt. Endo is getting better for complications like pseudoaneurysms, AV fistulae.
Okay, moving down to the abdomen. What are the key points there?
Abdominal vascular injuries are a big chunk, maybe 34% in one series.
Yeah.
Mostly penetrating, 89%. Multiple vessel injuries are common. Instability, low blood pressure, very frequent.
Which vessels are most common?
The IVC, inferior vena cava, and its branches. Then aorta branches, SMA, portal hepatic veins. Mortality is high, 30–60%, mostly bleeding. Hypotension is a strong predictor of death. We use a zone classification for retroperitoneal hematomas.
Okay. Zone 1, the aorta.
Blunt injury is rare, but high pre-hospital mortality, usually infrarenal if they survive. Intimal flap is common. Penetrating, mostly gunshot, less than 50% survival. Infrarenal most common. Direct to OR helps.
And the IVC, also zone 1.
Most common major abdominal vein injury, mostly penetrating, infrarenal, often with other organ injuries. Mortality varies high if isolated near the heart, better if isolated infrarenal without instability. Repair or ligation, historically, now shunning repair too.
Celiac and mesenteric, zone 1.
Rare, mostly penetrating. High rate of associated injuries, high mortality from bleeding, 20–40%.
Renal vessels, zone 2.
Uncommon, even though kidneys get hit often. Blunt and penetrating, equally common. Nephrectomy, kidney removal, often needed in penetrating cases, about 30% mortality.
Iliac vessels, zone 3.
Uncommon, mostly penetrating, gunshot, challenging exposure. Veins more common than arteries. Mortality, 28–49%. May be lower with damage control.
Right.
Blunt injury, often with pelvic fractures, controlling pelvic bleeding is key.
Zone 4, hepatoportal, liver area.
Highly morbid. Hemorrhage, associated injuries, tough surgery. Hepatic veins, portal vein. Mostly penetrating. High mortality, especially with combined injuries.
Finally, let's hit the extremities, arms and legs. Probably the most common ones we hear about.
Very common, yeah.
Yeah.
Civilian, 1–2% of all trauma, more lower than upper. Military, up to 50%, mostly blast. Penetrating is a more common cause of vascular injury than blunt here.
And tourniquets made a big difference in the military.
Huge reduction in pre-hospital death.
Yeah.
Civilian to extremity vascular injury has about 10% mortality limb loss combined. Higher for penetrating, higher for proximal injuries. Lower extremity injury itself predicts higher amputation mortality. Shunts are used more now.
Okay, upper extremity specifically.
About 27% of civilian vascular injuries. Blunt often hits the brachial artery. That's the most common one, leading to amputation in the arm. Compartment syndrome is a risk.
Limb salvage is generally good.
Yeah, around 90%. Blunt injuries have higher amputation mortality than penetrating, though. Military. 34% arterial injuries are upper extremity. Proximal distal, roughly equal. Nerve injury is a big factor for long-term function.
And the most common site overall?
Forearm vessels, radial ulnar. Both civilian military penetrating more common. Stab gunshot. Blunt forearm injury, usually with fractures. Higher mortality, limb loss. Function really depends on nerve, bone, soft tissue damage too.
Okay. Lower extremity, femoral, popliteal, thigh and knee area.
Most penetrating extremity wounds happen here. Blunt is now the main cause of popliteal injury, though, especially with knee dislocations, high risk there.
Right.
Femoral, common, superficial, and popliteal are common sites overall. Hemorrhage is the fear proximally. Ischemia distally at the popliteal. High rates of nerve injury, too.
And popliteal is bad for amputation risk.
Most common, single vessel leading to lower leg amputation. Femoral injuries are a major cause of death from extremity bleeding. Both femoral and popliteal injuries mean higher mortality and limb loss risk.
And further down, tibioperoneal, in the calf.
True incidence is unknown. Many are probably silent. Most blunt lower extremity vascular injuries involve these. Interestingly, single vessel injury here can often just be observed or ligated.
But multiple vessels are bad.
Multivessel injury means high risk of ischemia, amputation, often associated with fractures, soft tissue, nerve damage. Amputation around 10%, maybe more with blunt. Overall mortality is lower than with proximal injuries, though.
Wow, that's an incredibly detailed overview. It's clear this is just such a complex and constantly evolving field.
It is indeed. And to kind of bring it all together, the key takeaway is that vascular injury is still this significant, multifaceted problem. Civilian, military, influenced by a complex interplay of factors.
Right.
And while our ability to diagnose and treat has advanced dramatically a lot thanks to military lessons, endovascular techniques prevention is still the ultimate goal.
Absolutely. And a crucial part of that is understanding the epidemiology, right?
Right.
Who gets injured, how, what are the outcomes?
Exactly. That information is essential for public health initiatives, policy changes, things that can actually reduce the burden. We still need better data, more standardized measures to really track progress.
Precisely. That epidemiological view lets us identify risks, tailor strategies. It's an ongoing process.
Continuous refinement, yeah.
So here's a final thought for you, our listener, to consider. Given the remarkable progress we've seen, especially in military trauma care, what do you think are the biggest remaining barriers to getting those same improvements widely adopted in civilian populations? How can we bridge that gap to further cut down the devastating impact of vascular trauma? It's a really important question to keep mulling over. Thank you for joining us for this deep dive.